All right, welcome to this deep dive explainer on Chapter 375, the Vasculitis Syndromes. If you're here, you already know we're bypassing the basics today. We are getting into a highly detailed, super specialty level breakdown of these fascinating and often devastating diseases. At its core, vasculitis is a clinico-pathologic process where blood vessels get inflamed and damaged. This compromises the vessel lumen and ultimately leads to tissue ischemia. But as we're going to see, the way this plays out across different organ systems is just incredibly diverse. Let's get into it. To navigate this notoriously complex clinical landscape, we've got a clear algorithm to follow today. First, pathophysiology and ANCA phenotypes. Second, vasculitis mimics and diagnosis. Third, a highlight on granulomatosis with polyangiitis. Fourth, we'll run through other primary vasculitis highlights. And finally, we'll wrap up with induction and standard therapeutics. Okay, kicking things off with Section 1, pathophysiology and ANCA phenotypes. Let's look under the hood and unpack the underlying immunopathogenesis driving these severe inflammatory conditions. So the crucial point to remember is that vasculitis isn't just a one-trick pony. It's driven by a combination of different mechanisms. Depending on the syndrome, you could be dealing with pathogenic immune complex deposition, which is exactly what we see in IgA or lupus vasculitis. Or the driver could be pathogenic T lymphocytes causing granuloma formation, a classic hallmark of giant cell arteritis. And then, perhaps most famously in modern rheumatology, you have the production of anti-neutrophil cytoplasmic antibodies, or ANCAs. Now, this split right here is absolutely paramount for categorizing these diseases. You've got two major ANCA phenotypes based on their cellular targets. First is the diffuse cytoplasmic pattern, or c-ANCA, where the primary target is protease 3, found in neutrophil azurophilic granules. Astoundingly, over 90% of patients with active granulomatosis with polyangiitis have these PR3 antibodies. Contrast that with the paranuclear pattern, or p-ANCA, where the target is the myeloperoxidase enzyme, or MPO. This phenotype heavily maps to microscopic polyangiitis and eosinophilic granulomatosis. Moving right along to Section 2, vasculitis mimics and diagnosis. Honestly, in clinical medicine, knowing what isn't vasculitis is half the battle, because the presentation can be incredibly deceptive. You absolutely must rule out the classic mimics shown here before locking in a primary vasculitis diagnosis. Why is this so vital? Well, picture this. You've got a patient deteriorating rapidly with multi-system failure. The empirical treatment for vasculitis is heavy immunosuppression. If that patient actually has bacterial endocarditis, or maybe an atrial myxoma masquerading as vasculitis, giving them high-dose glucocorticoids could be catastrophic. You also have to be highly suspicious of drug toxicities, especially cocaine or levamisole-laced cocaine, which can perfectly mimic these inflammatory syndromes. So how do we nail this down? Here is the systematic, step-by-step diagnostic algorithm from the text. Step 1, like we just discussed, is aggressively ruling out those mimics. Once you've done that, Step 2 is definitive diagnosis, which usually demands a tissue biopsy, or, for large vessel disease, an angiogram. But here's a crucial caveat. Blind biopsies of asymptomatic, healthy organs have a totally abysmal yield. You must target the involved tissue. Only after Steps 1 and 2 can you categorize the syndrome and initiate the precise therapeutic regimen. All right, Section 3, highlight on granulomatosis with polyangiitis, or GPA. Let's use this as our severe systemic prototype to really anchor these concepts. Just look at the brutal reality of GPA here. Microscopically, you've got this intense necrotizing granulomatous vasculitis just tearing through tissue. You can practically see the inflammation and destruction. And clinically, that cellular pathology translates into what we see on this CT scan: multiple bilateral cavitary infiltrates in the lungs. It's a really striking visual correlation between microscopic damage and macroscopic organ failure. Plus, we can't forget the classic GPA triad, which hits the upper respiratory tract, the lower respiratory tract, and the kidneys. The renal involvement is super specific. It presents as pauci-immune glomerulonephritis. The term pauci-immune simply means there is a distinct lack of immune complex deposition found in the renal lesion. This is exactly what separates it from something like lupus or IgA vasculitis. Let's jump into Section 4, other primary vasculitis highlights. We're going to do a rapid-fire tour of several other high-yield syndromes you absolutely need to know. First up, giant cell arteritis. The major red flag here is its tight clinical overlap with polymyalgia rheumatica, or PMR.
These patients often show up with profound stiffness and aching in their hip and shoulder girdles. The kicker is that PMR responds almost magically to low-dose prednisone. But if you miss the underlying GCA, you are risking irreversible ischemic complications for your patient, most notably permanent blindness. Next is Takayasu arteritis. Because this predominantly targets the massive vessels, doing a standard tissue biopsy just isn't practical. So if you pick up clinical clues like diminished pulses or bruits, an arteriogram immediately becomes your gold standard step to visualize those compromised arteries. Pivoting to pediatrics, we have Kawasaki's disease. It's an acute, febrile illness mostly hitting kids under 5. You'll see the classic mucosal erythema and skin desquamation, but the thing that genuinely keeps pediatricians up at night, the massive 25% risk of life-threatening coronary artery aneurysms. In fatal cases, autopsies almost always reveal coronary artery vasculitis. On the flip side of pediatric vasculitis is IgA vasculitis, historically known as Haynock-Schönlein purpura. This one is driven by IgA immune complex deposition. Kids usually present with palpable purpura and intense colicky GI pain, but thankfully, unlike Kawasaki's, this generally carries a truly stellar prognosis, with many cases just resolving spontaneously on their own. To round out this section, we have cryoglobulinic vasculitis. This is a board exam favorite because of its very distinct lab fingerprint, cold precipitable immunoglobulins, and a massive 90% association with hypocomplementemia. But here's the real clinical pearl. It is strongly linked to hepatitis C. If you diagnose this vasculitis, your immediate next step is testing for hep C, because treating that underlying virus is often the absolute best way to clear the vasculitis. Finally, let's bring it home with Section 5, Induction and Standard Therapeutics. Let's see how we actually fight these complex inflammatory syndromes, specifically focusing on the heavy-hitting induction regimens. When comparing the two heavyweights for severe ANCA vasculitis induction, it's really a tale of two toxicity profiles. For decades, cyclophosphamide was our proven standard for inducing remission. It worked, but it came at a steep price, terrible risks of bone marrow suppression, bladder carcinoma, and infertility. Now enter rituximab, an anti-CD20 biologic. It's completely non-inferior to cyclophosphamide for induction and actually superior for relapses. The real game changer? It completely avoids those devastating bladder and fertility toxicities. But induction is really just the start. Long-term glucocorticoids will absolutely wreck a patient's system over time, causing everything from osteoporosis to avascular necrosis. So our primary goal is always to taper steroids as fast as clinically possible. We do this by leaning heavily on steroid-sparing agents like methotrexate or newer biologics like abatacept, which clinical trials show can maintain remission without the toxic baggage of long-term steroids. So I'll leave you with this to chew on. As our biologic toolbox keeps expanding, moving away from broad, toxic sledgehammers like cyclophosphamide to highly precise tools like rituximab and abatacept, are we on the verge of turning these previously fatal inflammatory diseases into easily manageable, targeted conditions? The incredible pace of rheumatologic discovery suggests that a future without immense treatment toxicity might be closer than we think. Thanks for joining me on this explainer, and keep learning.